Okay, I'm going to start off with one of the online questions. Is there a specific age by which children with PURA syndrome will develop seizures if they are going to experience them? I don't know.
That's a good question. I think, again, it comes back to the importance of a registry to actually know what the age range of seizure onset is. To my knowledge, there are individuals with PURA syndrome who have had their first seizure in early adulthood, but not very many. The typical age of onset is, as was stated in the previous talk, between 2 to 4 years in those individuals who will develop seizures, but there's a wide range. And of course, there are patients who are identified as having seizures as neonates. So why is it that some people do and some people don't? But the majority of patients will, of course, develop seizures during their lifetime, unfortunately. We don't actually know the answer at the moment. And again, we can't make that prediction based on the nature of the genetic change that is identified in the PURA syndrome gene.
Something that's come up in our POPs group over the past year or two was this discussion about vitamin D. And we know that most of our PURA kids, I don't know, well, at least some of our PURA kids are low in vitamin D. But then what we heard from someone, and I'm not sure who it was that is there evidence that vitamin D can cause more seizures or cause seizures to change? And so my question is more of like, what do we do with this information? Do we treat for vitamin D or do we pull back? Any knowledge on this?
So that was very loud. So I don't know specifically for PURA and vitamin D, but I will say that vitamin D deficiency is so prevalent. Probably, I would say 2/3 of the people in this room are going to be vitamin D deficient because we're all wearing our sunscreen and our hats, and that's great. But in our epilepsy practice, we screen vitamin D twice a year in all of our patients, and it can be quite low, and we do recommend supplementation. And I'll be honest, I have not heard ever, I've been practicing epileptologist for about 22 years. I've never heard of an increase in seizures with vitamin D specifically. Yeah. That being said, I'm going to say every family can tell me something that I've never heard of, and I tend to believe families. So who knows? Is it a formulation? Is it, I think there can be lots of variables, but if your unique individual had an increase in seizures and you've done a challenge, re-challenge, and you've seen that consistently, then I think you have information, but I'm not aware of any mechanistic reasons.
I have a number of questions for Dr. Said. Have you ever had an experience with felbamate or felbutol? We've had Sasha at the age of 48 developed status for the first time. She's had seizures since the time she was 11. She'd been on a number of medications, but then she developed status, and nothing helped until felbutol. And I know that's a seizure medication that people are very loath to use, but I was wondering if you've had some experience with that.
Yeah, so, felbutol is actually a very good medicine. It's one of our anti-seizure medications that came out specifically for children who have, or individuals with harder to treat epilepsies like Lennox-Gastaut syndrome. And so we do have, several children in our practice who are on felbutol. It can be very effective. I try to avoid felbutol and valproic acid together just because of potential liver toxicity, but we even have some children who need, or young adults who need both. So as long as you're screening liver functions. I think the treatment that works is great. And hopefully we'll learn more about why an older individual would go into status after a lifetime of not having status.
That's one of the questions I wanted to continue asking you, because it was hypothesized that it might be because she's going into menopause. And there seems to me like there's been very little research on seizures and hormone changes in women. And this has to do with the neglect of treating folks with these kinds of conditions in adulthood. So I was wondering if what you knew about that and what you might say about that.
I think you're right that the population of women, just in medicine, studies targeting them, there's a paucity. I think people are being much more intentional. There is actually now in the adult world, like women in neurology, women who take care of women going through all their life stages. What we know, and even in younger women, is that there definitely can be an increase in seizures related to hormone changes. We think estrogen is likely proconvulsant, although not every woman who has estrogen peaks is going through increased seizures at that time, but there probably is really a strong correlation, at least for some. And then being thoughtful about hormone therapy is also really important. So we're more likely to try to suppress estrogen peaks with continuous low dose progesterone, be it through shots or pills, but really trying to avoid the extra estrogen. And thank you for bringing up that really good point. And, and as we learn more and hear more about our children with DEEs growing up, we have to really be thinking about all of that and partnering with our adult colleagues.
Is it common for someone with PURA to have issues with anesthesia?
So I think the question was, is it common for people with PURA syndrome to have problems during anesthesia? So the answer to that is I'm not aware of specific problems, but obviously the nature of the condition would make you cautious about anesthesia. But many individuals with PURA syndrome will require anesthesia and undergo that very safely. Is there a specific sort of subtext to the question when you ask about tolerating anesthesia? Is it specifically general anesthetic or local anesthetic, or
just any procedure with anesthetic? So my daughter has a very unusual, according to the doctors, experience with anesthesia, where she will, when she comes to wake up, it can go on for passing out and waking up and gasping for air and passing out, and it goes on like that. So I didn't know if that was something because of the respiratory situation, if that was something that you guys had ever experienced.
So I think that the anaesthetist would probably take extra precautions as standard with children or adults with a diagnosis of PURA syndrome who are undergoing general anesthesia, because there will be associated risks potentially to do with recovery. But those, provided that the diagnosis is recognized and anaesthetists are taking appropriate precautions, this shouldn't be a major issue. Otherwise, though, in terms of the way that you frame that question, I'm not aware specifically of that pattern of problem in PURA syndrome, but it might be that you have some.
As a clinician and also a PURA parent, I get to see what people post on the Facebook page. And anecdotally, I see people posting that specific question and their experiences. And anecdotally, it has not looked to me like that's any more common in PURA than it is for any other patient. Some patients just have a little more trouble without a genetic syndrome or with other genetic syndromes. I don't feel like the numbers that I've seen have been any higher than the general population.
Thank you.
I also just want to mention too that on our website, under published research, there is anesthesia recommendations for patients with PURA syndrome that came out in October of 2019. There is a link to that report in there if you are interested in reading it. So.
Hi, I'm sorry. I was just going back to the anesthesia question. I was really interested in her question because I noted, like you guys had said, it's just in general anesthesia. Some patients might just have a respiratory problem that just grasp for air whenever they're in recovery. But what about for the babies who end up, I guess, prolonging that anesthesia medicine for days or even a week? My son had his trach at 6 weeks and he undergo anesthesia and he was out for like days when they told me that he would only wake up in a couple of hours.
I think that there are going to be inherent risks because of the low tone and because some of the breathing issues and dysphagia and so forth. So I think that is there, but I think we do just have some patients that have these odd responses to anesthesia, again, without PURA. So I don't know that there can't be something there, but so far I don't think that we're aware of something.
I'm sorry, will there be any more research into that? Like as far as what anesthesia does to PURA kids, as far as like it putting them behind. I know them being in the hospital regardless puts them behind developmentally, or even they may regress from where they were at before. But are we doing any more research as to what anesthesia does to the PURA kids or anyone with PURA?
So I don't think that's something that's being specifically researched, but it is something that is important as an observation potentially. So as is often the case, quirky things can happen. They may not be things which are directly recognized by clinicians or researchers who are interested in a condition, unless they're, sort of questioned specifically by families as something that they've noticed in terms of the way that their child has responded. But this is the sort of information that we do need to collect and to see whether it's an isolated experience or whether actually it is something that is seen as a repeated experience in individuals within the PURA syndrome community. So it isn't something that I'm aware of personally in the patients that I oversee, and most of them have had general anesthesia at some point. But of course, it's a small group of patients that I'm following up. And even though I'm very much interested in PURA syndrome, I can only be guided by what's published in the literature, what I know from my own patients and what I know from meeting people at the conference. But I think that if that is a concern and if there is talk about this on the online forum as being something that has been observed repeatedly, then it's the sort of information that we need to be trying to collect again through a patient registry and looking to put this out there in the literature. So it's a recognized sort of presentation post anesthesia. And of course, that would then filter into potential management guidelines for patients and making anaesthetists aware of what the outcomes of anesthesia might be and what additional measures they might want to take. Yeah, of course.
So to go back to that question, when I trained as a clinical geneticist, I did a study on the anesthesia, but not on the PURA syndrome, but it's a mitochondrial disease that can cause like a seizures, like a PURA syndrome. And we found that this is did in a mouse model. We found that the mouse model that has a genetic mutation causing like a mitochondrial dysfunction, you might not need like as much as general anesthesia like the healthy mouse. And from that, I just like try to be caution in every patient with like a mitochondrial disease. I usually like write what I call like an emergency letter or like a protocol, and that give it to the parents and say if this patient has to be anesthetized, you should just like increase the amount of anesthesia like very slowly, or this patient might just has just responded to like a lower amount than other people. So I think that this is, we don't know for the PURA syndrome, but we can do this kind of like a letter that I usually do in all like a metabolic or like a genetic patients, that just like an outline of what we know, what is the diagnosis and what we should aware, and just to make sure that everyone when read that letter know that what to try to avoid. Yeah.
Hi. So my questions are on medication. So I think we're all on lots of different medications for younger ones like Brandon. When's the right time to start talking about, should we start trying to not give him medicine or lower the amount, or when do we talk about giving him more? So in particular with caffeine and albuterol syrup, but what Keppra, Pepsid, any kind of medicine.
I think that has to be taken medication by medication. My one of my biggest interests has been PURA in the neonate and in the neonatal period. So caffeine and albuterol and all of that are very fresh on my mind always. Caffeine, I think, is mainly not only, but mainly addressing the central sleep apnea component that so many of our children have. And it seems as though many of our kids outgrow that. Different ages, maybe around a year of age. It can be younger, it can be older. And so I think the best way, I'm a huge proponent of starting caffeine in the NICU and remaining on it for at least somewhere around that time frame. And then I think they'll need to repeat a sleep study. Probably you would talk with your physician about, should you wean it off and repeat the sleep study without it? And I think that's how they can guide you about when to come off of the caffeine. My own personal opinion about albuterol is lifelong. It really depends on if, your child is responding to it and if they're having any side effects. But my daughter's on it, and I, at this point, plan to just never take her off unless there's a specific reason that I need to. I'll let Dr. Saeed address the seizure med question.
Can I jump in really quick, Lauren? Right,
Yes.
sorry, I'm right in front of you. Because there was a question online that said, when giving albuterol, is there a significant difference between oral or nebulizer in infants?
Yes and no. It's the same medicine. And so if you're getting nebulized treatments, you are getting albuterol. The problem that we're trying to address mainly is not in the lungs. Other kids are on albuterol because of asthma or lung issues. And so you nebulize it straight into the lungs, get it there directly. You have fewer, you're not putting it as much into the bloodstream, so you're not having some of the side effects that you can have to the medicine. So in asthma, that makes sense. In PURA, generally, the lungs are pretty healthy, so I don't want it to go straight to the lungs. I want it to be delivered systemically. I want it in the bloodstream, and I want it to go everywhere. And so it's just it makes a little more sense to give it orally so that you're getting it more systemically than into the lungs. But it's delivered either way. And when you try to look up like delivery via the lungs versus orally, they don't really understand exactly like how much gets delivered to the bloodstream via the lungs. We don't really know. But so if you're using it for tone and breathing issues, I would probably just go the oral route. Breathing issues like apnea, not asthma, of course.
The question about anti-seizure medications and when to taper, I think that this is very individualized, but a general rule of thumb is you want to get to a place where you feel you've had a long enough observation to see, did it help or not? And too short of a time is probably not giving you enough information, unless in a very short time things got worse. Well, that is something, you learned something, and I wouldn't persist on anything that made things worse. But I would say giving several months, really getting a sense, and then reassessing where you are. How much have seizures gone down? How much have they not changed? What potential side effects are you having from the medications or the polypharmacy, which means multiple medications together, that perhaps one medicine on its own might have less sedation, whereas if you add multiple, you might have more. And then that's sort of the delicate balance. When coming off anti-seizure medicines, if you added a new one and things got really great, then I would say, why are we going to keep adding more medicines on? And I think really judiciously taking off an old one is really important. We just can't keep collecting medications. You know, they interact, they have other side effects. So the last part of that, though, is you never know how much a medicine is helping. Is it because they're together working better synergistically, or would it have been helpful even if it was on its own? So the coming off of something process is also can be nerve-wracking, and it has to be done carefully. We're not stopping anything cold turkey. The way you went up gradually, you would come down gradually, unless there was a major side effect where you'd have to come off sooner. And just reassessing every visit when you're talking to your neurologist, you know, these are the medicines we're on. What do we think we need to be on? And keeping your own records, I think, can be helpful. But if you're now on medicine 4 and you're like 5 medicines in, you have to kind of go back and think, what was medicine 1 or 2 doing? Although I will say, sometimes we know like this medicine was really helpful for this specific type of seizure. And so we kind of want to keep it for that seizure type. And now this other one was helpful for this other one. So I haven't really answered your question other than to say, think globally, reassess frequently, and you know your child, and knowing that the coming on and the coming off are both times of extra observation.
Hi, over here. So we are like, I believe, the first confirmed diagnoses in Utah. And so as we have been navigating our journey, what do you guys recommend in terms of sending new primary care physicians or new specialties in terms of resources or learning more about PURA? Because I know that some of the medical literature they've found has been a little bit outdated. So it's, 2019 or 2021. And so as we, meet with new physicians or new specialties, what do you recommend in terms of us sending them somewhere aside from giving them your personal email addresses or anything like that?
Yeah, so that's a good point. So lots of the resources that are out there are quite dated now, including the Gene Reviews article that needs to be updated and will be updated this year. I think that there is a wealth of published literature, including meta-analyses. So if there are specific questions that clinicians are keen to address, they shouldn't have too much difficulty in finding relevant peer-reviewed articles. That's not to say that they shouldn't seek to contact clinicians directly, and they can do that via the PURA Syndrome Foundation. And there is now this clinician directory, which I would recommend that you signpost them to, because it may well be that there is a clinician that may not be local, but is based in the US, who can share ideas about practice, if not actually give you directive management advice. But the PURA syndrome community is large. There are lots of clinicians who are involved globally. So wherever you are in the world, you definitely shouldn't be feeling isolated. And I think that if you can prompt your healthcare professionals who are involved in your child's care to make contact with the PURA Syndrome Foundation if they're struggling with any aspect of your child's management, then hopefully they'll be able to help put them in contact with someone who can provide them with further information.
I have two questions. What about ADHD medications and the impacts and how they're helpful on our children? And is that something to look into to help focus in school or not wander around and so forth?
Excellent question. I've got to say I've had no experience in this at all. And I'd be really interested to know if anybody in the room has a child who has been prescribed medications for ADHD. I know that none of my own patients have. And from my review of the literature, I'm not aware of any published cases where this has been stated as therapy that is current or previous for patients, but I am still working through the literature. But yeah, I sort of open the floor. If anyone has anything to add in that respect, please raise your hand. No, it seems like, yeah, sorry, struck out, yeah.
I'll just add that tomorrow we are going to have a neurodevelopmental disability specialist speak. And I don't believe that she has any additional PURA specific information, but maybe she will have other thoughts on that too.
Well, this might be for tomorrow as well. This one's more of a grasping at straws, but red light therapy for developmental and epilepsy treatments. You hear talk about it now. I didn't know if that was relevant, if it's even helpful or beneficial for the child, or magic.
You know, I think it's really important that we both keep an open mind about potential treatments while also having a healthy dose of skepticism if something sounds very different than things that we have ever really used. I will say that the world is not always kind, and I think that there are people who try to capitalize on parents and their fear. And so, you know, I keep abreast of the epilepsy literature pretty tightly, and I will tell you that there is, you know, somebody's going to send me a resource now, but to my knowledge, there is no double-blind placebo-controlled trial that suggests that red light therapy is effective. And if you can only get it in one place, in one clinic, you've got to buy their machine, and you can only, you know, cash pay, you just sort of wonder, because science isn't like that. You know, science isn't hidden in a corner and only one doctor in one place or one practitioner can provide it. So, you know, and if it's only anecdotes, you know, that's not how science is disseminated. It's not by testimonials only. So I think the honest answer is maybe there's something to something, and we just use that as a spark to move forward with research. And sometimes it's just people thinking that I can capitalize on parents and their worries. So I would probably invest more in things that I knew were much more likely to be impactful, like therapies, assistive communication devices. I think that if you had resources and you had to put them to red light therapy or that, I would be putting it towards those therapies.
I just had a question for Dr. Said about the CSF glucose and the ketogenic diet. So I was just wondering if you'd comment on how easy it would be to get patients with PURA syndrome to get tested, their CSF tested. And then given that there are many epilepsy patients who are treated successfully on the ketogenic diet without a low CSF glucose, would you recommend that patients try the ketogenic diet based on your experience?
Yeah, that's a great question. So, you know, it's actually not that hard to get CSF. We do it in the hospital all the time. And you know, it is a lumbar puncture. I want to be very clear, but it's not really that hard. And I think that if we're really thinking about how we're going to move the science, you know, when we're talking about biorepositories and so forth, I think it really would be a valuable thing that we could get CSF glucose. It has to also be timed with serum glucose because you want to sort of, that's how you know it's too low. However, now, like as a clinician, I have a child who comes to me, here's where we are. I 100% think that there's no reason why we shouldn't do a trial of ketogenic diet. You know, it's a well-proven, this is not experimental in the epilepsy world. When we talk about refractory seizures, I think people think that means you have to have failed 10 medicines, but that's not actually true. If you failed 2 anti-seizure medications, then you should be thinking about what else is an option. And so definitely for that, I will say probably the biggest frontier is where do we go with pre-seizure ketogenic diet? Does it potentially have some neuroprotective effects? These are all questions, but you know, if your child, for example, is maybe at some point, you know, not super picky, you know, is not really yet maybe, you know, worried about Doritos and Cheez-Its and all those things that kids like, maybe it is something that you might consider trying. The difficulty is that when it's seizures, you have a clear endpoint. We can track it. We can say, what was our end game? Well, a reduction by so much. When it's for potential development, that becomes a much harder prospect because we know that our PURA kids already, they might have a harder course initially and then make some gains. So I think it really depends on what you want to do as a family. But I think it's not wrong to try it personally, as long as last part is it should be medically supervised. Please don't go rogue and start giving your kids, you know, like avocados and MCT oil, and they'll have elevated lipids and triglycerides. And we want to make sure that they're still growing and getting their nutrition. Yeah.
I'll add to that a little bit. And then I know that Mel was very involved in some of the GLUT1 stuff. And I think you as well, David, right? Okay. So you might have something to add too. But I will add that, well, first of all, a lot of kids with PURA have had the CSF glucose checked because when you have a newborn who's not waking up, that is fairly standard to do a sepsis workup, and part of that is checking the CSF. And so it seems like most of the kids with PURA don't have low CSF glucose. We just know that some have. And I will add that in GLUT1 transporter deficiency, the CSF glucose is not a perfect test. We have some kids with GLUT1 that we don't actually find low CSF glucose, or maybe sometimes we'll find it. So it's an imperfect test to begin with. And in PURA, could we sometimes have low CSF glucose? And so if we have one test without, is that ruling that out? I don't know. That's been something going on in my head. So me personally, just thinking of it, you know, I have a fantastic neurologist. It's Dr. Said. And I have put my daughter on the ketogenic diet. And I know that there's nothing proven there. And she had a normal CSF glucose when she was born. But to me, like, because there's a theoretical reason for it, it's been worth it to me. But when I talk to my own patients with PURA about it, I say, full disclosure, I'm doing this. I'm going to tell you everything I do for my daughter. I'm not going to hide any of that from you, but also, you know, it's hard and it really has to be supervised. There are downsides to it also. And so I'll generally offer to them, you know, I can send you over to Dr. Said to just hear from her and to hear from our dietitian about what that would really look like logistically. And then you just think about it and if that's something that you would want to try or not. And I don't push it at all. I just mention it.
All right, we have a few online questions coming in. Can the vitamin D correction help suppress gene expression? There doesn't seem to be much information on the impact of vitamin D on gene expression. I've heard instances where aggressive doses of up to 60 kIU per day were given to improve cognitive and physical senses in infants. Please shed some light.
I'm going to leave the gene expression to Dr. Hunt, but I will say just one thing. Vitamin D is a fat-soluble vitamin, and mega doses can actually be quite dangerous. So I just need to, as a clinician, say very clearly, this is not like giving higher doses of a water-soluble vitamin. And so there can be significant side effects, but I'm going to leave the changing gene editing to Dr. Hunt.
So I'm going to confess that I don't know the answer, and I don't know that there have been sort of systematic studies to look at that. But I don't think that taking excessively high doses of vitamin D is likely to be helpful in any way. So I would echo the message that actually you need to be cautious, and I think that sort of standard regimens for managing vitamin D are what is recommended, and that's what is evidence-based.
All right, the next question. I would like to know where to get more information on the metabolic side of controlling seizures in PURA. Is GLUT1 the main metabolic pathway we should be concerned with? Has sodium dichloroacetate, DCA, been successful as treatment? It's used as a cancer treatment and in chronic fatigue syndrome because of how it supports mitochondria and blocks metabolic pathways. Any opinions?
On or off up here. We're trying to be very polite. I think that the honest answer is, I don't think we really know. And that this, hopefully what in our conversations today, we've spurred on a lot of thoughtfulness about it, and much more needs to be done. Yes. Outside of PURA, what did you want me to talk about? Oh, yes, exactly, yes. Sorry, my friend here is prompting me. So we use the ketogenic diet, though, very extensively in refractory epilepsy. And the beauty of the ketogenic diet in refractory epilepsy is that it does not have to be specific to a specific syndrome or seizure type. That's actually the beauty of it. And we don't think that it's because of a underlying metabolic problem. It's that it's really how the diet works by providing more efficient energy source. I mentioned very briefly that it can shift to more, it can inhibit some of the glutamatergic neurotransmitters in the brain, which are excitatory. So it's working in a lot of other mechanisms, but we don't think that every epilepsy that responds has a metabolic condition. There are exceptions. Pyruvate dehydrogenase complex deficiency, GLUT1 transporter defect, but beyond those major ones, that's not the mechanism of action.
I have seen many patients with mitochondrial disease, and majority of patients, even with a genetic diagnosis like a common mitochondrial diseases, we don't have good medications for it, but we can give them like a coenzyme Q10, like or sort of like a mitochondrial cocktail. I have seen variable responsiveness from the patient. It's just, to me, it's I don't think that they have a very effective by doing giving the patient for that chronic fatigue syndrome, like a sodium dichloroacetate. I have seen many a chronic fatigue syndrome, and you name it, because now mitochondrial dysfunction is happening everywhere. So every disease is caused by mitochondrial dysfunction. But I never seen like a consistent result. I think that is more like I have to say it's kind of like a placebo effect, like when you give it and you feel good. But other than that, it's not sustainable. It's not consistent. Yeah.
So I actually have several questions for each different one, but first I'll address the ketogenic diet. We actually tried ketogenic diet, and every time we got him up to ketosis, the seizures went crazy. So we had the opposite effect. I just wondered if you'd ever had that experience. The second question to you is, do you have any thoughts on the procedure corpus callosotomy for seizure control in retractable seizures? So I guess I'll let you answer that, and then I'll go to
It is very important to know that any intervention could potentially not be effective. And it is well described in the epilepsy world that there can be worsening of seizures on ketogenic diet. It's rare, it's about 2 to 4%, but it's not negligible. And when it happens to your child, it's very impactful. And that's why in our practice, we see our patients that we start on the diet very frequently, especially in those first several months, because we worry about that. Regarding corpus callosotomy, it can be a very effective treatment for people who are especially having seizures where they fall and are hurting themselves. We still do that procedure, and it still has a very vital role, although there may be other procedures like vagus nerve stimulators that might help reduce seizure burden. But if drop seizures and people are hurting themselves is the major type, callosotomy is definitely one of the options that might be considered.
Do you have a thought on the side effects of that procedure? Does it make it worse?
Yeah, so most people tolerate it well. It's important to know, though, that you don't stop having seizures. You might stop having the drop seizures, but other seizure types might emerge. It's also possible that you don't get full disconnection, and so there may still be pathways, and so drop seizures might still persist. I have seen difficulties with walking after a callosotomy, and there are some children who have minor regressions of eating, and that becomes sort of problematic. And then vision can also be an issue. But I strongly suggest, these are very important individual conversations with your epileptologist. I think they will guide you based on your individual, person. Yeah.
Thank you. We also had the same effect with, because he was such low weight, so we were always encouraged to increase the calories, and to do that was always increasing the fat. Introduce more fat, and the same thing happened with the fat that we introduced.
Yeah, I think you've proven that it just isn't really a great strategy for him. Yeah, I'm sorry.
Often we'll think of or talk about the ketogenic diet almost like it's another seizure medicine or it's another seizure intervention. And just like every single seizure medicine out there seems to work for some kids with PURA, it seems to make some kids with PURA worse. We just haven't seen any perfect medicine that everybody's going to respond the same. So I think the ketogenic diet also, it potentially, and I think that's what we've seen. There have been plenty of PURA patients on the ketogenic diet. And for some of them, it's been very helpful. And for some of them, it seems like it made things worse or just didn't do anything. So I think in that sense, it's behaving just like any of our seizure medicines. I'll add that, because I said that my daughter's on the ketogenic diet. My daughter, thankfully, has not yet developed epilepsy. I'm doing it with this theory that perhaps there could be this neurodevelopmental protective effect. And I've not read anything or seen anything about anybody who's gone on the diet and remained on it for a significant period of time and that they've tried to compare development. So I'll just add that.
Thank you. Thank you. Second question was, well, I just want to make a comment on the anesthesia. We did have side effects to anesthesia. He's been under anesthesia many, many times. And a couple of the things that happened every time was low temperature, low blood pressure. I saw that happen many times, and prolonged effect of the anesthesia. We went through that many times until they were able to, I guess now he's been under enough times that they've been able to adjust that, but he did have those issues. Then I wanted to ask about the transition. I think for us, we're now into the adult phase, and that was one of the most difficult things for us is to make that transition, because we had a whole pediatric team for every discipline pretty much. We had a really good system going, and then we got to that point where some facilities are able to extend the period of time. Some, I try to get doctors that can do both. That's what I've learned. But in the cases, a lot of cases, we just come in one day and they wouldn't care for him anymore, even in a highly thought of institution. So that is a big problem for us. And that, you mentioned that you have a transition system and I just wondered if you could tell us how you do that so that we can take that information to other institutions as well.
Yeah, so at University of Washington in adult hospital, we have like a transitioning care and run by a combined board, like a pediatric and internal medicine. And she's very interested in like a transitioning patients. And when I look at her schedule, like one patient can take about like 3 or 4 hours, and they will meet like social workers, like so I think most of like a transition is not very hard from the treatment or like a medical perspective, but it's more like logistic as well as like a bureaucracy, like a try to do something, try to make things work and try to argue with the insurance, try to talk to the high up in the hospital that this patient needs this, need that. So I think that this transitional care should be in every hospital, like at least like some hospital that has like a children hospital affiliated. And I don't know, there are many models about it, but the model that I let you know about our institution is more like a run by one doctor, but there's a lot more like a coordinator, like a social worker, and like make one day like 3 or 4 hours, and then they will follow up again every 6 months until everything is settled. So this is some model that we see.
All right, we've only got a few more minutes and we've got a lot more questions here. So I'm going to try to get through some. If EEG shows our child operates daily with lower level brain waves, delta and theta versus alpha and beta, what are your thoughts on trying to increase brain activity to prevent seizures versus meds? What are the thoughts on laser light, brainwave therapy, or exercises to improve brain activity?
So we really wouldn't intervene just for slowing, and that's what these wave frequencies are, because I don't think there's really robust data that says that you can really change brain waveforms, and we know that they fluctuate. So if a child's drowsy, so if they did the study and the child was drowsy, they're going to be slower waveforms. If the child was awake and alert, they're going to be faster frequencies. And because it varies so much based on alertness, stage of sleep, all of these factors, I would not be chasing an EEG in that circumstance. And I think that the question about light therapy was brought up in kind of in a similar way. And I don't personally have any data to suggest that it is something that we should be pursuing aggressively at this point.
Do you have any thoughts on cannabis oil?
Yeah, so I look at CBD, cannabidiol, the pharmaceutical grade plant-based Epidiolex, which is an FDA-regulated formulation, as one more treatment, like all of our treatments. It's just another treatment, and it has the same chance of being helpful or not helpful the way any one of the number of therapies that we've already mentioned today. And so I think it's an option. I wouldn't necessarily push it higher to the list, but it doesn't have to be option 10 either. And some children do, or individuals do very well, others don't do well. I would say I would avoid artisanal preparations, especially that they're not as regulated. That becomes really a problem. And there's been some very compelling data to show that there's lack of batch to batch consistency, that one time you think you're giving your individual this dose, but the next batch, it's like way less or way more. It has side effects. And so for my patients that are on Epidiolex, which is the FDA-approved plant-based formulation, we follow them closely and watch for very significant medication interactions, liver functions. There's a whole slew of things, but it's one other option, the way any other potential medication could be an option.
Thank you. What have your experiences been as clinicians with pyridostigmine and salbutamol, albuterol? Have they been helpful in PURA kids? And follow-up question, do you still try these patients regardless of EMG normality, abnormality as marker of neuromuscular junction dysfunction?
I am a big proponent of both pyridostigmine, which is also known as Mestinon. So if I use the names interchangeably, I apologize. And albuterol, or in Europe, salbutamol, the sister medication, same medication basically. I love albuterol in our babies. I think that it helps a lot with the breathing and the tone and just vigor is what I say. And a lot of families, I feel like their baby's just more awake and just more vigorous on it. And I feel like it's been very helpful with avoiding tracheostomy in a lot of kids. I think pyridostigmine's great and has a lot of similarities and like what we're looking for with it. My own anecdotal experience with babies has been I've had more trouble with it, with babies not tolerating it as well, because we're having all the feeding issues and the swallowing issues. And when you increase the dose to what we might expect to be an efficacious dose, the secretion, the spit and everything gets thick. And I think it causes some more breathing and swallowing issues. So it's a little more problematic. But in older kids, I think either one would be a really great thing to try. I personally go albuterol, but some very intelligent people who know more about neuromuscular disorders than I do lean pyridostigmine first. So I think that if you personally or your physician have strong opinions, I think either way is a great way to go. Was there a second part to that?
Do you still try these regardless of EMG normality or abnormality?
Yes. So definitely the albuterol. I don't know that I would take EMG into account whatsoever. Just think like mechanistically, I'm not sure that it would make a difference. And then we tried pyridostigmine without an EMG. I think my thought is you can just, if you're going to try the medicine, you can try it either way. If you had an EMG and it showed the evidence of that there was a problem with the neuromuscular junction, that's more reason to try the pyridostigmine. But the test isn't perfect. Perhaps the technique of the person doing it makes a difference. So I don't even say we need to do that before we try those medicines. I think either way, anyone warrants a trial of those if that's something that the family is interested in.
Hi, thank you for this. Just piggybacking off of the questions on salbutamol, Jack has been on it for several months. I agree with your assessment regarding vigor. That has been our experience as well. How do you judge, and I am asking this personally, but how do you judge how much is enough and or how much is too much? We started at a very low dose, and of course, given the positive impact we're seeing, wondering kind of, is there room to go up, and or how do you make that call? I guess beyond just simply weight, how do you make that judgment?
Yeah, nobody knows. So I think when it started, let me back up. This is not a new idea. And it's not unique to PURA. It came from some other pediatric neuromuscular disorders where they have proven that this has been a helpful medication. So it was kind of adapted from that. And the doses in those other disorders are a little bit all over the place too. I think they kind of used, I don't know, I see someone in the back who might have more information about that than I do, but I think they probably just said like, these are doses we use of albuterol for other things. Let's just try that dose. is what it looks like to me. And the doses in those other disorders are higher than what I start. And I have found that a really itty bitty whiff of a dose actually seems to do a lot. So I usually start people on a really tiny dose, and then we just decide together, like, let's go up or let's not go up. People like clinicians don't love oral albuterol. It used to be the treatment for asthma. Some of y'all might have been on oral albuterol for treatment of your asthma when you were a little kid. But it can cause some side effects. Like you can get really jittery and your heart rate can go up, and it can cause some changes to your heart rhythm on an EKG. So I don't push it high if we're already having a great effect. And if I am getting a little bit higher, I do monitor EKGs periodically. But I feel like PURA kids are responding to little itty bitty doses, and then I just go up some based on families' feeling about how they're doing on it. It's a very imperfect answer.
Unfortunately, we're out of time. Our clinician, I think most of our clinicians are going to be around, so in person, people can probably get your questions answered outside the panel. And you can also email questions to the foundation, and we'll try to help get those answered as well. Thank you very much for all our clinicians on the panel.